Oh, good evening. My name is David Hagedorn, and I'm the CEO and Chief Science Officer at Evoke Neuroscience. We also have a practice in North Carolina, and in the past year and a half, we've been getting busier with complaints of children and adults with post-COVID symptoms that have been rather elusive. So that was the reason to try to put something together, because not only has the research in the last year been very helpful in guiding assessment and treatment, but it's well funded, and I expect we'll see quite a bit more research in this area, and I'm most certain that all of you are experiencing similar situations with your patients and some of their complaints, and we kind of initially we were throwing up our hands, not knowing exactly what to do. So let me start by saying that there's been a number of terms thrown around for what the sequelae are and what we're calling this COVID response after the acute phase has passed. Long haul syndrome has been one name thrown around, so you'll see different versions. Most conventionally now, people are using the term long COVID, and Congress appropriated over $1 billion to be funded in just 4 years to take a look at what is going on. And the NIH initiative is to identify some of these prevention and treatment options for people who become sick and symptomatic, mostly central nervous system, as you'll learn today from this. So the people that have been infected with this SARS-CoV-2, which is a more specific term for it, and I'll use the word COVID in general terms, but I'm referring to the SARS-CoV-2. And we are certainly all seeing that more and more patients are complaining of the fatigue, some respiratory symptoms still, but predominantly this brain fog term with some types of sleep disorders. Often it's insomnia, occasionally still some fevers, GI distress, and mood and anxiety disorders are just the tip of the iceberg. And the concern really is that we're just starting to see patients who are infected now, and symptoms are starting to pop up many months later after they had and survived COVID. Just a real quick talk about the mechanisms of action through the coronavirus and how it damages the nervous system. The virus enters through the blood circulatory pathway. There's hypoxia possible when people are anoxic for periods of time during the COVID recovery period. Perhaps not far different than what we see when people have pretty severe apnea. It certainly impacts the frontal lobes. We know that to be the case, and appears also that the hypoxic damage with COVID is a big problem. Neuronal pathways via the olfactory nerve, and that olfactory nerve to the olfactory bulb, that's a particular pathway of interest for a couple reasons. And also the spike protein is binding to ACE2 with a pretty high affinity, and that seems to play a key role in this brain invasion, like we like to call it. So the ACE2 is a clear component and pathway that we are mindful of. COVID's been shown to use sensory and motor neural pathways to impact the central nervous system. The neuronal pathway, again, via the olfactory nerve and role of ACE2 has been observed to be perhaps the primary pathophysiological mechanisms. So that seems to be a real target for us in our assessment of the patient, and when we're acquiring and doing a history and looking at even when it's more acute, we're trying to treat them, early. The neurotropic capacities of this virus seems to allow them to evade the immune response for an extended period of time. So it seems to lie dormant for good length of time. We don't even know how long. For sure, 6 months is what we've observed already, and other researchers are reporting this as well, with the short and long-term complications of COVID. So they've also found in a postmortem, we're seeing the virus found in the brain tissue itself. Again, most of this research that I'll be highlighting today is all within the last year. Only a few beyond more than 12 months out. The neurological findings have mostly been central nervous system, and you can see the terms used, Guillain-Barré and encephalopathy. Really, those are terms that probably fall in a very similar category in terms of the pathophysiology that's taking place. We're getting brain altering dysfunction and the immune system impacting the nerves, with probably happening systemically through the whole body. But the majority of the neurologically found symptoms have been central nervous system. But again, the whole body is a single fluid system, and there's not a sharp dividing line between CNS and PNS. In terms of imaging, some very interesting findings have come out from the recent literature, and it started back early on in 2020 already, when there were some routine CT and MRI being done. What's interesting is that the CT has been pretty much unremarkable in terms of its utility clinically to identify the COVID abnormalities and damage. So, we know the specificity in spatial resolution is not the greatest. It has certain applications for other conditions, no doubt. But for this particular disease, and for sure long COVID, it's questionable how useful CT really is to us. MRI is better. Of course, getting it approved is sometimes difficult. But even then, Piscini and other researchers are finding that a lot of their patients also had no findings on MRI. And I use the term no findings versus normal because there is resolution differences on the machines. And I doubt that the brain is normal on these cases. It's just the MRI results didn't detect anything. So, even then we're wondering how valuable MRI is going to be. So if you do get an MRI, and it comes back no findings, don't necessarily consider that the brain is clear, especially if you have not done an EEG and a QEEG, because it seems that the EEG, because of its advantage of very fast resolution and low cost, we can get a pretty good functional idea from the EEG what's taking place in the brain. And when you add on the value of quantitative EEG, it opens up a window into the EEG that you can't just get from the raw morphology alone. The other advantage is if you do happen to get QEEG data, it can then guide you to more specific treatments. And on this example in the image here, I'm going to cover a little bit later, because the results actually guide some treatment options. So that's the added advantage. Kapanska in Poland and others in Germany, and also at the university where she's at in Poland, make a very important statement here. They're very emphatic in their findings that EEG and QEEG offer a unique opportunity to observe how these different pathogens, including COVID, affect the human nervous system and interfere with the function of the neural network during the disease process. And also, they also state whether these changes in the brain are only transient or rather leave a long-lasting impact that we can also use to track our recovery pattern. And in fact, that's what we're doing in our office. We're using this data to track recovery, so we know that we're there when we finally get there. Standard EEG can be very valuable. So a routine EEG is very reasonable. Certainly, I think it's certainly indicated, and I would do that in conjunction with QEEG, not in isolation, so you don't miss that whole side of the analysis of the EEG. This year in the journal Neurology, a very good study was done with 102 patients with a pretty good wide age range, stratified evenly with males and females. Only 3 of those people of the 102 had normal EEG, and the rest had forms of rather significant eleptogenic events, abnormalities in the EEG, which is shocking to me because the majority of routine EEG, as you all know, comes back no findings. When you know the patient has clear brain problems, yet a routine EEG is biased towards a no findings output or a normal result. So for this to come back with only 3 that have a normal EEG is shocking. Now, granted, these cases, they were sick people as well with comorbidities, but the comorbidities listed don't typically cause an abnormal EEG finding unless they're very severe. And also this year in the Journal Annals of Neurology, an even larger sample size, 197, a little bit more of a narrow age group, but probably a more representative group of those who get this COVID and it's very risky in terms of their age range being at a higher risk. You can see here the typical type symptoms, seizures being almost 10%, which is significant, and non-convulsive status epilepticus as well, being another 5. So between the 2 of those, you got some significant and consistent eleptogenic events to the paper that Menon authored. But what's also of most importance, I think, is these often missed epileptiform abnormalities that sometimes in routine EEG reports don't get commented on as much as I think we would like. And about half of the patients had these other features. So, there was some controversy about how frequent seizures take place, but their finding is that the seizure activity and the epileptiform events are rather common in patients who have COVID. And we're assuming that is from the cytokine release and the inflammatory process that's taking place there that's triggering this. Also, the authors highlighted significant frontal and temporal hypofunction, and that's hypofunction is found in the QEEG and in the visual inspection of the G as excessive slow content. And we call those frequency bands that are in the slow frequency band, typically delta and theta, but even into the slow alpha frequency band as well, around 8 hertz, 9 hertz as well, is quite a bit of idling in those regions of the brain. So the frontal, temporal, and frontotemporal regions, they also highlight in their paper. This table here illustrates, and it was just sort of, by chance that this research was pretty well designed at the time when we needed this to try to look at what's going on with patients with COVID. They took a look at a number of brain functions from a neuropsychological perspective, looking at different types of memory, processing speed, frontal lobe function, types of memory, types of language processing. And Dr. Becker's finding the sample of 740, she found that 2/3 of these patients had, again, that reported brain fog, which is really, if you distill down the criteria to throw that term around, it's mostly hindered memory functions and slowed processing is what defines that brain fog. The impairments that were most common were, again, executive function, no surprise, that's frontal lobes, and the cingulate, which is frontal central. And these type of executive function symptoms are lack of ability to focus, poor decision making, slowed processing, can also add some mood components because of the involvement in the frontal lobes, the dorsolateral prefrontal cortex, left and right. Slowed processing speed, no surprise. And then the fluency, expressive speech, Broca's area is left frontally and is involved. So there's a processing of language delay, recall of information. So, quite a bit of distress that people have. And I just talked with a nurse yesterday, she was treating COVID on the front line, as we call it, had COVID, recovered, went back to work, but since then just can't remember things. And her position in a hospital with managing medications and setting up PIC lines, et cetera, her memory is really important, necessary skill for proper patient management. So it's questionable if she doesn't need a minor leave of absence till we could get her better to go back. So these symptoms, ER admissions have been correlated, of course, with the severity of COVID, but also there's a worsening of cognitive impairments if people have COVID bad enough where they need an ER admission. Perhaps from this research, again, this is published in the JAMA this year, perhaps the most prominent deficits from their findings of a very large sample is this processing speed, executive function, but really the memory represents a big piece. If you were to group, the memory types together, that's by far the majority problematic symptom. And by happenstance, the Imperial College of London under Dr. Hampshire in 2020, when COVID hit, they had already started a very large intelligence study in Great Britain. They had 81,000 participants, and during the course of the study that was ongoing, over 12,000 had COVID. So it was, hate to use the word luck when you're talking about human suffering, but in fact, it was, from a research standpoint, quite fortunate because they were able then to see what's going on from a cognitive function standpoint with a very large sample that would be unheard of to get in any research study that's not extremely well funded. And what they found was a low IQ score that was, almost 3/4 of a standard deviation in intelligence drop from COVID. So, that's a lot. I mean, that's a person that, if you would put it in real terms, was capable of going to college, and now it's questionable that they'll be able to hack it at the academic level. That's enough. That's the deviation from intellectual quotient score that these people had. And the primary impairments were poor concentration and verbal processing, where, we all remember going through academia, and I teach in academia. If I have students with poor concentration and verbal processing difficulties, they're not going to do well. They'll drop out. So this really is a frightening finding to me, because we have a lot of people that have had COVID, quote unquote, survived, weren't hospitalized, walking around, but now functionally they're really hurting, and it's not a small number. It will certainly have a ripple effect around the world. Just a quick scan over some of the other studies, not a lot of time to talk about each one, but just to kind of put a few pins in the wall, so to speak, on a few findings. Several really good papers that between last year and this year in particular, that attention and executive symptoms are commonly reported. I've mentioned that a few times already. Just wanted to throw a few more references up there that these are not just single papers saying this. Everyone is now saying the same thing. The hypoperfusion to the frontal temporal region was again reported in another paper very early in the COVID research days. Thalamic and temporal regions involved with brain structures. And I'll just stop on the thalamic component now, because the thalamus is an important generator for your alpha rhythm. And we are seeing some kind of screwy looking alpha changes in patients. So it's either they're having excess alpha 1 or even a very high alpha 2. The alpha 2 we'll talk about its connection with PTSD in a few minutes. But that alpha, when we do a QEEG, we have a little window into the thalamic processing, the thalamic clocking speed for the patient. So that's another important insight with the testing that we can provide them. Again, slowed information processing was detected with all different types of viral infections. Obviously, this paper in 17 was before COVID-2, but we had SARS and MERS, and they were finding that the information processing damage was due to demyelination. And we're seeing the similar type of damage with COVID-19 is demyelination damage. Again, another reference, Kumar's paper is excellent one on talking about the executive functions, attention and memory, perhaps being the top 3 problems that we see. And then lastly, the Vasuli paper is good because it looks at this temporal slowing, the delta, theta, and alpha 1 frequencies that are, real significant problems in our QEEG. We can see them quite readily. And again, another reason why EEG is of tremendous value to us when we're evaluating and tracking long COVID. The reason I liked this paper and why I'm talking about it, it's a case study of one 80-year-old female. But the authors were very meticulous. It had multiple measures of this lady when they were evaluating her. And what I liked is they really dug deep and determined with a good degree of certainty that the EEG changes were indicative of a progressive neurological process related directly to COVID and the neurotrophic properties of that virus. So that's one of the reasons this is of quite a bit of use to us to understanding the pathophysiology of this disease. And also it supports the need for and the appreciation of COVID-19 as a cause. It's actually causing these cerebral problems and the disturbance that are manifested and that we can see on EEG. And the virus itself being a cause, not necessarily the side effects like the hypoxia, which is what was discussed in 2020, that some of the cognitive impairments was assumed to be due to some of the physical side effects of the disease process, but it seems that the virus itself is quite insidious. The non-hospitalized group, again, I mentioned them with respect to college students in passing, but it's a very important one because a lot of people experienced COVID and they just kind of bounced right back. And it seems to be that not all of them are immune to symptoms of long COVID. So this sample of 100, it's a reasonable size, but what we're noticing from this study from Graham this year is that there's an impaired quality of life in the cognitive and the fatigue areas of their inquiry. Some depression, anxiety, and it's easy to chalk that up to social distancing, wearing a mask, people are inside more, but I don't think that's necessarily the only reason. I'm not going to dismiss it as a partial component of mood disorder, certainly, But I believe there's more to it with respect to long COVID being one of the impetus for those symptoms. Fatigue was reported in 85% of the non-hospitalized group. And again, brain fog comes up, which is again memory related, lack of focus, and slowed processing speed. So another very good paper in Annals of Clinical and Translational Neurology, lending additional information to us about a large number of patients who will come to your office and they'll say, oh yeah, I had COVID back in February, and I did pretty well. You know, I was home for a couple of weeks, and then I kind of got back in the game. But ever since then, I've really been having trouble, driving, not being sure where I am, having trouble with speech. I mean, that's what we're starting to hear in the clinic. So the authors, Troyer and colleagues, last year in 2020 posed that, if this COVID-19 is in fact similar to the SARS and MERS, so it was their question at the time. So if similar, then the expectation is that we will have a crashing wave, as they call it, of neuropsychiatric symptoms that are going to follow. And they say that they projected that if that was the case, we would have a pretty large implication for trouble around the world in management, in healthcare, and absenteeism, organizational and economic growth. All those things were falling under this crashing wave. So a pretty good prediction based on what we saw with SARS and MERS. And in fact, the Oxford University researcher, Dr. Kumar, and her colleagues, they reported that in fact the past coronaviruses of SARS and MERS from 2002 and 2012 respectively do in fact seem to be very similar to what we're seeing with COVID-19 and are manifesting similarly to the neuropsychiatric pathology. So in fact, this wave is among us. We're seeing it. They claim that about 20% of the people are going to have symptoms long-term that include PTSD, depression, memory loss, insomnia, emotional dysregulation, which is again a frontal lobe function, anxiety, panic attacks, OCD, often a central midline abnormality in the brain that's overactivated, fatigue, different types of pain conditions. Again, that would be peripheral, but also central, because the brain's pain networks are in the central nervous system and involve the sensory processing system. So the pain conditions will also implicate the central nervous system and not purely be peripheral and part of the peripheral nervous system. And another paper by Rogers, again, last year, so very early on, they did a nice work of looking at the 2020 study. So again, it was pretty early still in the research window for COVID, but the Bose paper found that almost every person met criteria for PTSD. Now, a lot of studies never even ask the question. They don't do a PCLC test, just screening tests for PTSD. But when those people that are doing the research do include that questionnaire, they're surprised to see how high PTSD is among those who've had COVID. And if any of you have had it, you know how frightening it is, especially before Regeneron became available. The thought was, if I get it, I'm going to die, and it's frightening for many, many people. And that's what drove a lot of people, last year to, in the medical field, basically rush to Health and Human Services to try to get the vaccine. I've also highlighted some clusters of significant amount of patients that have impaired attention and impaired memory. Again, attention and memory is the big problem with long COVID. And you see when you combine attention and memory, you're getting a significant amount of the people with long COVID that have those difficulties. And again, a majority of the papers are also identifying the central nervous system as being dominant. And again, this was a rather early research last year, and also what we found this year certainly supports all of that and adds even more clarity. But the point of this slide is, don't dismiss PTSD, because if you are trying to treat everything else and you're blinded to an ongoing PTSD, which of course you will know includes anxiety and insomnia and irritability, you may be trying to treat that with medications, for example, when perhaps the use of a non-drug therapy for PTSD makes more sense, which would be EMDR would be the certain go-to right out of the gate. There are other treatments as well, but that would be the first one. So don't miss that possibility, because I think a lot of times we're so focused on these other CNS findings and frontal lobe dysfunction that we miss the fact that there could be PTSD there as well. So let me show you a case that I hope highlight some of these points that I'm drawing out today. So this is a 34-year-old male, and these images on the right are from the Evoke Neuroscience report. So I just plucked these out of one of the doctors in Washington, D.C.'s patient that they were so gracious to send me. I have several of my own, but I thought it would be nice to use one of the doctors that uses the Evoke system with his patients. And so this is a 34-year-old male who's pretty healthy until COVID, and post-COVID reports sensory motor problems, particularly some muscle weakness and some word finding difficulties. As you know from how the report looks, the very top image on page 1 is subjective data. You have 6 categories that the patient gets scored in based on answering questions, and these questions are loaded to have a certain affinity towards these 6 categories of brain function. And you'll see that word fluency and sensory and motor were the biggest complaints. And under the memory, just below that, everything was fairly even, except semantic word knowledge and temporal orientation were, quite almost half in terms of capacity of those areas of memory function. So it's again consistent with probably some temporal abnormalities with respect to, identifying words, being able to pull up words that you want to say. So no shock, because that is one of the unique findings that we see with long COVID. So it goes along with memory loss, but there seems to be some language processing components as well. And he also then has motor difficulties, which are going to implicate nerve damage, peripheral nervous system nerve damage, perhaps. He reported again that he had brain fog with panic and anxiety. And if you'll note here, his reaction time or his response speed, which is a combined cognitive plus motor score, because it's when you press the button to a target stimulus. And for a 34-year-old male to have a 604 millisecond score is pretty slow. And additionally, for a 34-year-old to have an elevated variance, and again, that variance score means that his response speed was quite variable. And typically a healthy brain is not variable, it's very consistent. So it's not, egregiously high, but it's definitely a soft sign that there's something going wrong with his central processing. Heart rate variability is certainly worth looking at, in particular with COVID. You'll see why in a moment from some of the papers I'll show you. But this case study here, it doesn't look too bad really. But again, you don't have his premorbid measure. So if we had premorbid, he might have been at 2,500 on power and 75 on his SDN. His resting heart rate's fine, but his SDN is in a low normal. He certainly has mostly sympathetic arousal. You can see that red bar. And we know sympathetic arousal is elevated with PTSD and anxiety, and he's already reported anxiety. So it's no surprise to see it. But what we know about COVID is that heart rate variability is tremendously sensitive to COVID recovery and even early acquiring of the virus. We can detect a significant CRP climb that's correlated with the drop of your heart rate variability. So looking at HRV both in the assessment stage and following a patient for treatment is very useful. We saw a physician yesterday who had COVID, and he wears heart rate variability equipment now to monitor every day. He's been monitoring his recovery, and during COVID, his heart rate variability was just dropped so low. He recorded all of his data, for a long time, so he had a good lot of baseline, and when he got COVID, it just plummeted. And we're now seeing it slowly starting to recover to his baseline, which is a good sign, and it also correlates with his self-report of recovery. So that's a low-cost option using heart rate variability with your patients. The evoked potentials. So again, a 34-year-old with no prior problems, his attention was only mildly delayed. You see the P3A, not too bad. I wouldn't necessarily be overly alarmed by a score like that, again, because I don't have his premorbid. But his P3B, is a little bit delayed. I'm, a little surprised to see that delay, but he is reporting memory complaints, so you're likely to see that correlation. And when his memory complaints improve, I would expect that P3B to, get below 500. What's interesting as well is the sensory delay. The visual processing is mildly delayed, 280. Now, if this is an 80-year-old person, a 7-year-old person, that's not a surprise to see a visual delay like that. But in a 34-year-old previously healthy male, to have a delay of 280 milliseconds for visual processing is noteworthy. So here's his QEEG, and what's of most utility to us is to see a couple things. We have generally, as you recall, green is within normal limits of Z-scores, and what we see is that this is eyes closed. I should have put the eyes open next to it to show you the difference, but I put an arrow at 10 hertz. In eyes open, he did not produce elevated right parietal 10 hertz. When eyes are closed, he did show a 10 and 11 hertz elevation, which we know is a classic sign of PTSD. In almost every patient I've ever seen in decades, when they present this pattern, they have PTSD. There's a very rare when this has not been the case. And again, that's no surprise. He's reporting anxiety and he needs to be worked up for PTSD. It's something I'll pass on to the provider if they're not already attending this lecture. And the other finding is this right frontal and central beta. And what's unique about this, and where is the location of where the report of where that frequency is generating from, it's coming from the middle frontal gyrus. Brodmann area 9, and it's over 2 standard deviations from abnormal. That right area of the brain is largely responsible for emotional regulation, but it has other functions, executive function, language, and olfaction. Remember, we talked about smell being very unique and commonly abnormal with people with long COVID. Even children will report things like, I feel like I smell burning barbecue all the time, or different kinds of odd smells that are atypical. So the olfaction part of that network is involved, and we can see on the QEEG that these are problems, and these are now our treatment targets. The beauty of having this data is it doesn't just help you validate the symptoms, but it gives us a target to treat, which I'll touch on in a moment. But before I do that, the Alzheimer's and dementia. the Alzheimer's Association in particular, and the World Health Organization with 30 other countries have formed an international multidisciplinary consortium. They're now in the process of collecting and evaluating these short and long-term consequences of COVID on the central nervous system. Why? Because the belief is that this is going to be a real problem with our dementia numbers going forward. We know that COVID seems to trigger MS. We know it seems to trigger Parkinson's or make them worse. All the findings, again, from SARS and MERS, and now also COVID, is that we're going to see an increased spike in dementias. And the type of dementias is yet to be determined. If you were to ask me to predict a guess, I'm going to tell you it's going to be frontal temporal dementia. And you know how insidious that is and how difficult that is to treat. But that would be my guess as where it's going to settle. And they're looking at that now, fortunately, and this has been quite recent, but we're starting, I'm so pleased that all the countries are banding together to take a look at this. I mentioned heart rate variability in that case, so let me quickly make a couple comments about it and get to get to the end of our talk. But heart rate variability has been found to correlate very highly with CRP, which you all know, of course, is a very good and commonly used inflammatory test. So we will routinely do high sensitivity testing of CRP as well as other testing, ANA, etc., homocysteine, things like the A1C, which of course causes vascular dementia is a problem when you got an elevated A1C, or excuse me, vascular inflammation rather. So, but this study is quite interesting because of their correlation with as CRP climbs, HRV drops, and it became a very predictive model for them. And we know that from several studies that have looked at heart rate variability, particularly the SDNN score, which is one of the scores you see in the Evoke report output. It's a number that you can start to look at with your patients and use for the recovery trends. This study here by Adler, they looked at a large number of patients. I'm sorry, rather small number of patients. They had an N of 18, and but the group was consistently showed that compared to their control group, that the RMSSD, SDNN, the PNN50, these scores of heart rate variability time domain measures were all quite low post-COVID. And I'll just tell you from with our own patients, we correlate the improved numbers with their recovery, and it seems to be following quite well. And it gives the patient something to look at every day and motivate themselves to do the things we're asking them to do. Fitbit funded a study of a pretty large number. Now, what they did was they extracted data from users. So they didn't actually put together a controlled study. It's a little not as ideal as I would like, but what it did do was tell us that you can get a lot of information from a very cheap PPG sensor that can do calculations of interbeat interval. Like the cardio read, I think is $79. The Fitbit, they range from 100, 200 range. Heart Math has got one a little over 100, 100 and a quarter, somewhere in there. There's many other good heart rate variability devices. And of course, your Evoke system has heart rate variability recording and training built into it as well. So there's a lot of good support coming out with home use, consumer grade heart rate variability tools that allows you, to encourage patients to train at home. What's nice about the cardio read is they can export that to you in an email and a text file, take screen captures of their trending scores, etc. Some of the other devices allow you to do similar tools like that, so you have an idea of what your patient's doing and if they're recovering. So SARS virus that can cause neurological changes. We see it visible in the quantitative EEG. We see alpha patterns being abnormal. The EEG allows us to detect problems and dysfunctions in the ICU. So it's a cheap thing. They don't have to get wheeled up to radiology. You don't need to do, get them prepped for MRI, get them prepped for a CT. It's something very quick that can be done even pre-ICU in the ER. But my preference would be for them to, in the hospital settings, to manage the acute problems that are going to cause death, and then let their primary care providers and specialists handle EEG, QEEG, and treatment options. That would, to me, be a better use of resources and reducing the burden on the very packed ICUs and ERs. EEG is a tool for assessing early brain problems, and it's cheap enough that we use it to track progress. And we know we're seeing delta and slowing in the frontal lobe areas predominantly. So these prefrontal abnormalities, EEG is probably the best tool to try to detect that because of its good time domain sensitivity. In terms of then what to do with the data, let's conclude by saying that if you can measure QEEG, you can train it. And Kapaska and colleagues made a very good point. They say that an accurate QEEG diagnostics may create a solid basis for considering the regular use of EEG biofeedback, also called neurofeedback, as an individual treatment form for your patients in whom have neurological sequelae from COVID. And we know from, and again, they highlight this in their paper, that because we know that it's been helpful in dementia, autism, and ADHD, and there's countless studies around the world that support this, that it makes sense that QEEG neurofeedback is going to likewise be successful with long COVID. The Evoke system, of course, does neurofeedback. More biofeedback options from Evoke are on the near horizon. The Versus home training tool through Evoke will be available next year. It will have more options to treat your patients at home, in the office, with long COVID. It gives you some options. And finally, early intervention, really important. We think that you catch things early, and if you're talk to your patients about their symptoms, there are things we can do. We can use electrophysiology of heart rate data, EEG, ERPs, QEEG to track their progress, to detect the level of severity early on, and guide HRV biofeedback, EEG biofeedback, and possibly even adding in transcranial electrical stimulation to be an additional tool to help stimulate glial cell activity, BDNF. We know that TES does that, and that can also help a person's brain recover. Now, what I did not talk about is the enteric nervous system, nutrition. That's a whole nother lecture on the application of those tools in your armament for long COVID. So we made it a little over 45 minutes. I hope this was useful to you. Again, always feel free to reach out to us at Evoke Neuroscience with your comments, your questions, your ideas. We welcome them always and are happy to get back to you readily. Thank you all for joining this lecture, and have a wonderful evening.